with the deceased donor transplantations. And the topic for today is extremely, extremely important because it deals with organ retrievals. Now, any transplant surgeon can have a call at the middle of the night to go and retrieve organs for a prospect transplant in their center. And this session can prove to be very, very vital if somebody needs some important tips in how to correctly retrieve organs, because that is the most vital step in a disease donation transplantation. Because any mistake anywhere in retrieving the organs can really complicate the whole matter and the transplant. And today we would be trying to cover both multi-organ retrievals as well as for those urologists or transplant surgeons who sometimes need only the kidneys to be, or who sometimes get the opportunity to only retrieve kidneys, and they are probably not well trained in retrieving just the kidneys without the liver team probably retrieving the kidneys for them, or maybe retrieving the liver themselves. So, to start with our session, I first like to invite Dr. Mathur sir. Sir has been a stalwart in the field of transplant. Mathur sir, very, very good evening. Thank you for accepting our invitation and joining today, sir. Very good evening to you, sir.
Good evening. Good evening. And thanks for inviting me.
Sir, we have none other than Sanjay Kolte, sir, who's the president of the Society of Indian Society of Organ Transplant. Sir has been a doyen in transplant science and has been doing n number of transplants in the city of Nagpur and around. Sir would be chairing today's session as well. And especially, sir, we need very, very crucial tips from you for the kidney only retrieval specifically, sir. Thank you for joining, sir, and welcome to today's session, sir.
Thanks, Akshay. Thank you so much. Look forward to
And
hearing
also,
from Dr. Vishali also. Yeah.
yes, sir. Also, Dr. Sonal Asthana, sir, would be joining us very shortly. Another a very senior organ retrieval and transplant surgeon. So, her would be joining us very soon. So our session would start with Dr. Vrushali Patil, ma'am. Ma'am is a senior transplant surgeon, very, very experienced in multi-organ transplants. And ma'am, welcome and very good evening. We are really looking forward for your presentation for today, which is mainly on the multi-organ retrieval aspect of the donation. Ma'am, welcome.
Good evening, everyone. Thank you very much for inviting me for this ISOT webinar series. Thank you, Dr. Sanjay Kolte, sir. Thank you, Dr. Mathur, sir, for being here for my webinar. If there are any mistakes or if there are any corrections to be needed, please stop me at any point of time. Your experience and knowledge would help not only the group, but also to me also in my future. So, in my experience, the difference between a smooth retrieval and a compromised one is rarely knowledge. It is basically of consistency. And given the breadth of multi-organ retrieval that we have, I won't be going into the regular step-by-step video technique, but I will focus on the key principles and decision points which really define the outcome across all organs.
Right, ma'am.
Most important, yeah.
Ma'am, we'll get back to you, ma'am. Let me please welcome Sonal sir. Sonal sir has joined. Sonal sir, welcome and good evening.
Hi,
Sonal.
Sonal. Yeah. Sonal. You said Sonal has joined, no? Yeah.
Yes, sir. Yes, sir. Sir has
Yeah.
joined.
Good evening, Sonal. You are on mute. Yes.
Good evening. I'm so sorry. My OPD is running over.
Okay. Okay.
Yes.
So we have started the webinar with
Yes, sir.
expecting you would join soon, and so
Sure.
nice of you to have
I
joined.
mean,
Thank
I'm
you so
just going
much.
through Vishali's slides.
Yeah.
Please continue,
Yes, sir.
Ashal.
Yes.
I'm sorry, Vishali, we interrupted you. Please carry on.
No,
Yes,
thank
sir.
you, Sonal, for being there. I
Right.
mean, Sonal, you can also correct me if there's anything that I miss out on. And
No, for sure.
So,
So,
I mean,
Vrushali
multi-organ,
ma'am,
yes.
ma'am, 1 second, ma'am. Ma'am, so after Vrushali ma'am's extensive discussion on the multi-organ retrieval, all the young transplant guys, especially the young urologists, are waiting to hear Muruganandam sir's session on the kidney only retrieval part. So, Muruganandam sir, very, very good evening and thank you for accepting our invite today.
Yeah, good evening, good evening.
Sir, thank you. Sir, we'll get back to you, sir. Let's start with the multi-organ session first, sir.
Yeah, sure. We'll be watching. Thank you, thank you.
Thank you, sir. Vrushali ma'am, the stage is yours, ma'am. Please start, ma'am.
Okay. So, before any surgery or before any procedure, I think it is important for any retrieval surgeon to go through a checklist and to make sure your ABCs are correct. That is the ABO confirmation on the donor with the recipient that you intend to take the organs for. The brain death documentation is important to check that the brain death document is signed and it's verified with the same donor, and consent of the particular organs or all organs is present. Next is, of course, important also to understand for any retrieval surgeon is what the responsibility lies. It is not just being the operative part, but important to document all the key retrieval events that usually happen. A retrieving retrieval operation is a very dynamic operation. Things can change dramatically when there's a patient goes into hypotensive crisis, or a different team changes its method, or you have to kind of there's a different finding in the abdomen. So it's important to document any key retrieval events that occur. It's important to complete the operative summary post your surgery and to communicate with the recipient surgeon for whom you're taking the organs for, and important to correct label the organs. It is an estimated operation time of 4 to 6 hours. So one has to respect the timeline over here. One has to respect and coordinate with the teams that are going to be operating along with you. So taking all into consideration, you have to remember that the warm ischemia in the organs should be as minimum as possible, if preferably less than 30 minutes. A preparation also goes into what instruments that you take along with you. One should never underestimate or overestimate the donor operation theater or the operating the retrieval center. Never assume that because the retrieval center is in a city place that you will have everything in it. I can give you an example when I was in Pune and once in a Mumbai hospital expecting that things would be present. Sometimes the saw is not working, the retractor is not there, or the TURP cannulas are not there. So important to take along with you some things which you might not find in a donor retrieval hospital. I usually do a checklist. I usually take a picture of all the instruments set and give it to my operating team or the nurses, scrub nurses, so that they are well aware of what they're going to take. And there is no confusion, because in the middle of the night, the operating team might change, the nurses might be different. So take especially your clamps, the biopsy guns, the vascular suture staplers if you're going to do a small bowel or pancreas with you, the retrieve retractors and sternal saws are some things that you cannot really miss out on. So you should, if possible, take them along with you. You should also be aware of what cold solutions you are going to take. Always take more than adequate with you. There's always a possibility that you might run out, you might need more fluids, or your team which has come over there might or may not have brought the solutions. You might have to share with them. And there's something which is useful, that is a slush machine. It is a very cheap and inexpensive one available on even Amazon for about 5,000 to 6,000 rupees. It can be ETO'd, it can be sterilized, and this can help give you a nice soft slush of ice instead of those hard rocks which can damage the organs. I think let's go on to the important steps of the operation. A midline incision is usually taken from the xiphus sternum up to the pubic symphysis. And then depending on whether you have a self-retaining retractor or whether if you don't have it, then a cruciate incision is what is required. A self-retaining retractor is usually a cheap thing, but it's an important aspect of your of the retrieval process, where a complete exposure of the entire abdomen is important. In today's multi-organ retrieval, we will be talking only of the intra-abdominal organs and not be talking of the thoracic organs. Probably they will be covered in another series by the ISOT team. When we open the abdomen, like in this case where the retractor is not available, the abdomen is open through a cruciate incision and the flaps are either held in place by towel clips, or you can use a 5-number Ethibond, which is a very strong suture and can attach it to the patient's abdominal wall, thus exposing the abdomen completely. key things to be noted immediately as you open the abdomen is to see if there are any obvious injuries, any neoplastic growths anywhere, is there any anomalies, you can see any diverticulum or any abnormality that you can see, any focus of abscess, hematoma or injury. So feel and palpate the liver if it is smooth, if the lobes are rounded, if there is any hypertrophy of the lobe, if there's any surface irregularities. Look at, feel the bowel from the DJ flexure up to the ileocecum to see if there's any growth felt. Open the lesser sac to see if there's any tumor in the pancreatic region. And look in the fossas to see if there's any obvious collections or abscesses or hematomas. So it's always important because these will define the outcomes for the recipient. It hardly takes about a few minutes to do that. The next important step is really to expose the lower distal aorta and the IVC. See, the main focus principles of any retrieval is to, after exposing the organs, is to flush out the blood from the abdominal organs and replace it by perfusion solution after the cross clamp. To do that, it is important to identify the distal vessels first. So loop them and make sure that you are ready, and later on do the fine dissection process for each and every organ. To do that, we have to go through what is the cattle brush maneuver, which we all abdominal surgeons have been doing it for colonic surgeries or renal surgeries. And this involves dividing the mesentery and the retroperitoneal along the right colon up to the right hepatic flexure, sometimes slightly going up to the transverse colon also. And reflecting that will expose the distal aorta and the IVC. The colon is reflected medially as much as possible. You identify the distal aorta at the bifurcation of the iliacs, go slowly around it and loop the distal aorta. Sometimes, if it is difficult, if there are a lot of adhesions, or if it is possible and if you know that you're going to need some good length of vessel, you can even loop each of the iliac vessels separately. That is, the common iliac on the right side and the common iliac on the left side can be looped separately. And a single loop is looped around the aorta proximally also. As you can see, the inferior mesenteric artery over here in this B picture, that is usually tied off. The reason that we tie it off is because one is it gives you a good distal length of the aorta to put the cannula in. And secondly, when you're infusing the solution, you're preventing the wastage of the solution going into the colon. So the inferior mesenteric artery is tied off. You can lag it in continuity or use a strong suture like a number 1 silk or 2-0 silk tie and tie it off the inferior mesenteric artery. Once you do that, you get a nice good length of the distal aorta just above the bifurcation. You don't necessarily have to loop the IVC. You just have to let it be because sometimes the small tiny venules which can going into the lumbosacral region which can tear and cause bleeding. So it's only the aorta that you have to loop. When you're doing that and going around the aorta, try to go from the right to the left. The reason is you want to avoid injury to the IVC. So when you try to do that, the segment between the IMA and the bifurcation is usually the place where there are no distal or lateral branches from the aorta. This is therefore becomes a safe area that you won't injure or cause any injury to any smaller arterioles or vessels coming from the aorta. Kind of a relative avascular plane. The tissues along the aorta are then dissected over the aorta, going higher up to the where you can see the IVC or the left renal vein going across the aorta. That's also the region, as you reflect the bowel up, you'll also see the inferior mesenteric vein as a prominent blue vein arising just at the DJ flexure or draining into the splenic vein at the DJ flexure. One should loop the inferior mesenteric vein with 2 rows slit ties if you're planning to do a portal flush. Previously, portal flush was only done by the inferior mesenteric vein, but one can do a portal flush directly on near the infrahepatic and above the pancreas, suprapancreatic region through the portal vein also. This is especially, I would say, a choice of the portal vein flush is usually preferred by the pancreatic surgeons because if you flush it through the inferior mesenteric vein, the pancreas can become edematous. So nowadays, especially with in India, that we have we have a lot of liver surgeons who practice living donor liver transplant, and therefore are very comfortable using the portal vein flush directly through the main portal vein instead of the IMV, which makes the job a lot easier for the pancreas transplant surgeons. But Traditionally, the IMV is kind of looped over here, just at the DJ flexure, keeping about a 2 centimeter distance between the loops. At this point, we're not tying off anything. So this is how a small catheter is passed into the IMV. And you can do it now, or you can do it just before the cross clamp. These catheters could be in the form of a small infant feeding tube, either a 10 number or 8 number feeding tube, can be done depending upon the size of the IMV. Similarly, if you're looking at multi-organ retrieval, or if there's a possibility of an aberrant vessel, or you might need a SMA, as you reflect the small bowel up, one can feel the superior mesenteric artery tightening up vertically, and that can be looped using a vascular loop or even a 2O silk tie. The superior mesenteric artery is identified just above the left renal vein. The more vertically you hold the small bowel up, the easier it is to identify the superior mesenteric artery. The more lax your assistant surgeon is, or the small bowel starts falling on the patient's upper abdomen, the superior mesenteric artery can be difficult to identify, and the thick tissue, areolar tissue around the artery can cause the planes to become very diffuse and for difficult to alienate the artery around from the surrounding structures. So when you're at the superior mesenteric artery, make sure that you have wrapped the small bowel in a nice warm cloth and asked your assistant surgeon to lift the small bowel as high up to the roof. That will make the superior mesenteric artery taut. Go around it, and we can put a vessel loop around it, or you can just mark that area. Once you have identified and looped the major vessels, that is the distal aorta, you put a proximal loop 1 number silk tie or 1 number silk tie distally. You have looped the inferior mesenteric vein. Now you are in a safe zone. When I say safe, it means that suppose the patient becomes hypotensive or starts crashing, you'll have your vascular control and you'll be able to put the cannulas very quickly. Once your looping is done, one can now focus on the liver and then go to each organ and do some minimum standard mobilization that is required. Here, the preferences might be different. A lot of surgeons like to do a warm dissections first, and some of the surgeons might like to do the dissection in the cold. It all depends on the preferences and what you feel comfortable with. Essentially, there are some important steps. That is, once you look at the liver, you identify if there are any aberrant vessels or replaced vessels. You feel in the hilum on the extreme right side, just where the bile duct is, just inferiorly, if there's any replaced right hepatic artery, feel for any pulsations there. Secondly, in the lesser omentum, in the left triangular ligament, feel for if there is any gastroepiploic region, feel for if there's any replaced left hepatic artery also. If you think that there is a replaced vessel, be very careful as you go around the tissues over there. Secondly, you can, here I have not shown, but you divide the right triangular ligament, the left triangular ligament, and you can place a small sponge underneath the left lobe of liver while dividing it so that you don't injure any blood vessels. Once you mobilize that, you come to the hilum. Here, you can identify the gastroduodenal artery. You can identify the common bile duct. Later on, you can feel up for the pulsations and gradually course along the common hepatic artery and identify its branches. The gastroduodenal artery, as it enters into the duodenum and the pancreatic region, the common hepatic artery with its branches, the splenic artery going into the distal pancreas, the left gastric artery going towards the stomach, and if there's a replaced artery, you can feel the pulsations over there. You just see as much as tissue as possible around it. The common bile duct or the is usually divided at the distal insertion of the cystic duct or at the insertion of cystic duct. And you can leave a small stump, a very small stump near the duodenum, and leave a bigger segment with the liver. Second comes as the bile duct flush, where essentially the gallbladder is nicked, held with a sponge holder, and you can use normal saline with betadine solution and flush the gallbladder out. Flush out the bile from the gallbladder along with any small stones, so that the outflow comes out from the distal end of the bile duct. Once that is done, one can also use a very small 18 French IV cannula or a 16 French IV cannula and flush the bile duct using from the distal common bile duct end also. The bile is essentially flushed out because if you retain bile in the gallbladder, or if bile retains in the bile duct for a long time, it can be potent nidus for infection, as the bile is as we all know, is a good culture media. So essentially, right now, what we have is the liver mobilized from the right and left triangular ligament. We have the hilum dissected with the major arteries. We have to remember that you never go above the gastroduodenal artery, origin of the gastroduodenal artery, or the GDA in the when dividing the hilum. You'll preserve all tissue as much as possible. Don't try to probe in the bifurcation of the hepatic duct or the right and left common hepatic arteries, right and left hepatic arteries separately. You try to avoid that. You also try to avoid seeing the portal vein or dissecting the portal vein unless you really want to dissect the hilum out completely. The safe steps are to preserve the hilum, let it be for backbenching or for the recipient surgeon, but just save the liver, be safe on the liver, be cautious on the liver hilum. Secondly, once we have done that, once we have looked everything, and if the thoracic surgeon teams are also ready, you start looking at your cannulas. Depending on the aortic lumen, you can decide which size cannula you want to use, whether you want to use a size 20, you want to use a size 24. Different kinds of cannulas are available. Some of them have a small ridge at the distal end, which helps you to snugly fit in the aorta. While if you are short of cannulas, you can also use a small chest tube drain catheters, which are easily available, and they can be placed depending on the size of the aorta, the diameter of the aorta that you have in place. Now, in this picture, you see a small cannula in the IVC, which usually is not done, especially because we try to vent out or flush out the blood through the thoracic region. But for some reason, if there are no thoracic organ takers and if there is no other need to open up the chest, then one can vent out the blood through a distal IVC by putting in a small cannula or just put in a small nick once you have cross-clamped and started the perfusion. So it will avoid an unnecessary thoracic incision if the organs are not going to be taken. In a standard procedure, organ retrieval, usually the chest is also opened, and therefore, when the thoracic surgical team is also there, or if you are doing a rapid retrieval, one can vent to the suprahepatic cava, and at that time, you don't really have to put the cannulas in place. So, putting in the cannula is an important step. Your loops are in place. One can, as I said initially, you can loop the distal aorta by a strong one number slip ties, or you can use umbilical tapes, which have been a standard procedures in the past. So you can use 2 umbilical tapes and always keep 2 extra umbilical tapes in handy, just in case they snap off when you're tying them. And always keep extra ties in handy again. Sometimes the ties tend to snap at the last minute. Give clear instructions to your co-assisting surgeon that when you're going to put in the cannulas, tie in the distal vessels first. That's a distal aortic loop if it is there, or if you have tied each iliac separately, tie them nice and snug. Later on, with your left hand, hold the aorta as you can see here. Your loop is still in place and open. Make a small nick. Before you do that, make sure that your TURP set is connected to the organ perfusing solutions. Okay. And there is no air column in the tubing in place. Secondly, if you're all ready for the cross clamp, make sure you have discussed with the thoracic team and with the anesthesia team. If everyone is ready, then the anesthesia team usually gives heparin 30,000 unit heparin for an abdomen if it is a multi-organ retrieval. This heparin is used to prevent microvascular thrombosis and therefore allow for better end organ perfusion and therefore preserving the organ vitality and viability for a longer time. So once you have your control over the blood vessel aorta between your finger and the thumb, with the vessel loop also in place, you make a small nick into the aorta, just enough so that your cannula can be inserted. Ensure that you can take your time, be careful, don't push it in a hurry. Introduce the cannula in gently. Make sure that the cannula is in place and there is, you can see, pulsating blood flow coming into the cannula. Ask your assistant to, while you hold the catheter into the aorta snugly, ask your assistant to put in a nice, firm, secure tie. If that tie becomes loose, do not panic. Use quickly. You can put a clamp or you can put in a another loop catheter around it. I have seen some people using vascular clamps and then introducing the cannula. That can be tedious to do it because when you have to remove the clamp, as the catheter advances, it can be again distal bleeding and can create panic. But yes, if you're comfortable doing that, you can do it to achieve control. The method of introducing the cannula is also important. Don't shove it in because it can lead to a dissection of the aortic wall, especially if the aorta is atherosclerotic or has some plaques in it. A dissection of the aorta at this point can lead to the problems in the perfusion because it might lead to just partial perfusion, or too much of introducing the cannula higher up can lead the kidneys, the perfusing fluid might not flush the kidneys properly. So it's important that you don't push it too hard, too much forward. At the same time, do not shove it directly that you dissect the walls. And be careful when you tie. This is the most important step in the organ retrieval process. That is to secure the cannulas properly into the aorta. So once you have put the aortic perfusion cannula in place, also you have to make sure. I think I forgot to tell you that supraceliac aorta, when you're doing the dissection of the hilum, it's also important to identify the supraceliac abdominal aorta. This is very easily identified when you divide the left triangular ligament and you feel for pulsations just above just near the crura and the posterior abdominal wall muscles. Divide the muscles around it, especially moving towards the right, near the left lobe of the liver, so as to expose at least about the 2 inch of segment of the aorta, and you can go around it or just create space enough so that you can put the clamp over it. If it is going to be difficult, if the abdominal compartment is very short and shrunk, then one can even clamp the aorta in the chest, in the thoracic region. You can ask a thoracic surgeon to do it, or you can do it just in the chest after dividing the inferior pulmonary ligament. So essentially, your supraceliac aorta is looped. You have put the cannula in. Your 30,000 heparin is gone. You should wait for 3 minutes so that the heparin is flushed and reaches all the organs. As I mentioned earlier, the aortic clamp in the supraceliac region can be at the supraceliac part, or it can be just at the diaphragm, or it can even be in the chest higher up. This is just to prevent the flush from the abdominal organs to be entering into the chest, and this will allow maximum flush of the abdominal organs with the minimum amount of fluid. This fluid is pretty expensive. It costs about 15 to 30,000 per liter, so it's important to use it judiciously. So essentially, we have over here a clamp in the supraceliac or thoracic region, a tubing in the inferior mesenteric vein, a tube in the distal aorta, and if we are not venting in the chest, there'll be a tube in the IVC. Otherwise, you don't need a tube in the IVC. And when the thoracic team is ready for cross clamp, you've told your perfusionist also, everybody's on standby, and everybody decides and agrees for cross clamp. Then the thoracic supraceliac aortic clamp is placed, cross clamp, and then the fluid infusion is started, and the suprahepatic IVC is then divided just above the diaphragm. It is important that when that is done, you discuss with the thoracic organ team, as surgical team, as to where you're going to divide the IVC in the chest. As the inferior hepatic in IVC enters the right atrium, at least keep about a centimeter to 2 centimeter of length above the diaphragm if possible, so that it allows for the liver transplant surgeons to have a good length to do the anastomosis. Once an agreed upon line is marked and then divided, and so that once the IVC is cut off in the suprahepatic region, all the flush and blood will start flowing out. At this point, make sure that you put in a lot of soft ice slush all around the liver, in the kidney region, and in the small bowel. Open up the lesser sac and put some slush also in the pancreatic region. Everybody is different, but it's always important to have soft slush of ice. The more hard rocks that you put in, that can cause cold injury to the organs. Keep as of at least 6 to 8 liters of fluid is flushed from the aorta into all the organs. And how do we know that we have achieved adequate flush of the organs? One is the small bowel starts looking pale and white as soon the flush starts going there. Secondly, the outflow from the suprahepatic IVC, as you can see over here with the finger in the IVC here, the outflow becomes much more clearer. It's not, it does not show any blood in it. That indicates a clear flush coming out of the organs. That shows that your flush is quite adequate. So once that is done, then it is a coordination of how you, in what sequence the organs are removed. Usually the thoracic organs are removed first. If your thoracic surgeon is amenable and there's enough space for you to also operate at the same time, you can work in coordination in synchrony at the simultaneously also. If your thoracic heart lung surgeon wants you to wait for a few minutes until he retrieves the organ, you can give them that space and time until they remove the organs. Usually, the heart and the lung organs are removed about 5 to 10 minutes of cross clamp after the organs are flushed completely. While for the liver, it should within about 25 to 30 minutes, your liver should be out. Usually, it takes about 5 to 10 minutes, 5 minutes to get the liver freed from the diaphragm, and about 15 minutes to divide the hilum. As you can see, when you started dissecting, you had mobilized the liver from the right and left side of the triangular ligament. You had also mobilized the hilum, identified the common bile duct, and the arterial branches were already looped. So just a matter of time being meticulous and making sure that you do not injure any accessory vessels. So once you're ready for mobilizing the liver, an incision is started, you start clearing the diaphragm, leaving a small area around the liver, going from midline from the IVC down to the right lobe, to the right inferior margin, the right triangular ligament is already divided and reaching up to the hilum. Similarly, medially up to the aorta is divided, and so that the liver is freed from above superiorly, medially, and laterally. At the hilum, it is important to go step by step to ensure that you do not go anywhere higher up. As you leave as much as length as possible, don't dissect higher up into the right hepatic artery and left hepatic artery as mentioned. Once the duct is divided, you can see the GDA, divide the gastroduodenal artery, you'll see the portal vein. For if the pancreas is not being retrieved, you can go as deep down where the splenic vein joins the superior mesenteric vein. But if there is a pancreas procuring surgeon, then leave at least about a 1 to 2 centimeter length of the portal vein above the pancreatic border and can divide the portal vein over there. I have found that this struggle of having a good, decent portal vein was more in the West than in India. As I said, here we come across more living donor liver transplant surgeons who are more generous and allow the pancreas surgeons to have a good, decent length of portal vein, which is actually a boon for all of the pancreas surgeons. So dividing the portal vein just about a centimeter above the above the margin of pancreas, superior border of pancreas. Once you divide the GDA, you come across splenic artery. Also, again, similarly, give adequate length for the pancreas transplanting surgeon because rarely I have seen, unless there's a replaced vessel, that the splenic artery is utilized by the liver surgeons. Similarly, the left hepatic branch and the common artery is hepatic artery is traced down up to the celiac origin, up to the aorta, and a small opening in the aorta is made, or you can use a small aortic patch, and then the liver is removed. So this is where the portal vein, as you can see, is about a centimeter is left for the pancreas surgeon and divided. Once the liver is out, there comes a pancreas retrieval. Essentially, we have already opened the lesser sac once to see how the pancreas looks like. It is important to see if it is fatty, if it has got any tumors in, if it is feels firm or hard, and if there's any hematoma on it, and that is communicated to the pancreas recipient surgeon. If not, one can proceed ahead by uh, releasing the pancreas from the gastroduodenal vessels arcade by using the ligashore or by tying each vessels as you come up to the margin up to the splenic origin. The spleen is left intact with the pancreas. The essentially for the pancreas, one has to disconnect the C of the duodenum, that is the first part, and up to the third part. The remaining part can be discerned or divided on the backbench. So what we do is just after the pylorus, the stomach is divided using GIA staplers. Now, for the pancreas procurement, it is also important before we divide the staplers that the stomach is flushed with amphotericin betadine solution. Now, every pancreas transplant recipient surgeon has a slightly different way of doing it, but we all know that the duodenum has a lot of fungal elements. Candida are found more in the C of the duodenum, and therefore, to allow a good flush and to ensure that to minimize the infection as much as possible, The stomach and the duodenum are flushed with amphotericin betadine solutions prior to dividing the staplers. But dividing the first and the third part of duodenum. So the duodenum is divided using GIA staplers. The pancreas attachments to the stomach to the transverse colon are gently divided using either ligashore or ties, silk ties, or what is sometimes available is called as the LDS stapler. The pancreas is connected to the mesenteric vessels, and therefore the mesenteric artery is gently divided and firmly divided, either using vascular staplers or using individual tough ties like one number silk ties. Especially if there's going to be a small bowel procurement, one has to identify at what length of superior mesenteric artery we are going to divide. So you'll have to give adequate stump to the pancreas region and also a good length of stump to the small bowel team also. So when there's a small bowel in place, the small bowel is divided at the DJ flexure and the first part of duodenum. If the small bowel team is not going to be there, then one can have the liberty to use as much length as possible. The pancreas is usually held by the spleen and gently lifted up and released from the retroperitoneum using sharp dissection, and to ensure that you don't divide any major blood vessels. As I said, a GI stapler is sometimes used with a vascular load cartridge to divide the mesentery, and then this is again oversewed using 30 or 40 Prolene sutures at least twice because they contain the bigger blood vessels, the SMA and the mesenteric vein and the mesenteric arteries, which can bleed profusely at the time of perfusion. So here the pancreas is, this is the way the pancreas is removed. And for the small bowel, again, the mesenteric veins and the artery, as we discussed, is dissected off from the SMA, from the origin of the SMA, leaving a small stump of the pancreas. Kidneys has been going to be talked by my next speaker, but essentially kidneys can be removed en bloc or they can be removed separately. And when removing en bloc, it is important that you dissect immediately and directly on the vertebral bodies where you can feel it, leaving a lot of tissue on the vessels so that you don't injure any anomalous or an extra renal artery or renal vessels draining into the IVC or inferior pole renal artery, which is arising from the lower part of the aorta. Sometimes the veins can cross arc above the aorta or beneath the aorta, so it's important to be careful that you go divide just above the vertebral bodies, so preserving any tissue if possible. Sometimes kidneys can be, most of the time, the kidneys are preferred to be divided in situ. It's at that time that the left renal vein is divided. The IVC is preferred not to be divided. Leave it to the right kidney transplanting surgeon so that they can have a good cuff. And then the aorta is split into half. So it is important over here that the heart and lungs, within 15 minutes, both the organs are out. The liver, preferably between 20 to 30 minutes or 45 minutes at the most. Pancreas can take about 30 to 70 minutes starting from cross-clamp because the 15-20 minutes are usually taken up by the thoracic organs and the liver organs. The small bowel, again, within 60 to 90 minutes should be able to be procured, and the kidneys can wait for about an hour or 2 hours until all organs are removed. In multi-organ retrieval, vessels are very important. Sometimes the organ vessels are short. Sometimes because of the recipient anatomy that one has to use a jump graft or a conduit, that at this point that you might need iliac vessels. So especially if the patient has got portal vein thrombosis or some arterial problems or the artery is dissected or is very short in the hepatic artery, that one might need extra vessels. Or if it's a pancreas transplant or a small bowel transplant, you might need an extra conduit to add to the length of the vessels. So here is where your iliac artery and iliac veins are very important. So we really tend to remove them from the bifurcation up to the origin of the femoral vein or division up to the femoral artery. The whole length, if possible, are removed. Even if they have an arterial line in it or a venous cannula in it, it's important to remove them as gently and as carefully as possible. It's very easy to cause holes in especially with the iliac veins, or the iliac artery can tear the inferior So the small branches which are going in the depth. So it's important that you remove them gently and again put them in the vessels containing in the containers containing UW or HTK solution. If the donor is young and if you think that iliac vessels have been cannulated or they might be dissected or if there's somebody else needs more vessels, one can use carotid grafts or carotid vessels also as vascular grafts. Also important that when we have removed all the organs, all the instruments and the counts are correct and the closure is also done as decently as possible. As in some families, they tend to have a viewing of the body is done. So it's important that they are able to appreciate that the surgery is not done in a very crude manner and that the abdominal surgery was performed in the most respectful way as possible. So the closure also should be done in a more careful way in a single wall closure technique. Again, technical failure at the bench or the challenges in recipient surgery begin with the decisions that are made in the donor OT. So it's important to, at the time of cross clamp, that you communicate with each other, identify any anomalous blood vessels. Do not be in a hurry to push the fluids too much excessively with under too much pressure, as it can cause endothelial disruption. Ensure that you've got wide cannulas in place so that the flow is smooth and does not need too much of pressure. When removing the ureter, remember that blood supply is axial. Leave a lot of tissue on the medial aspect. Always give generous vessel length to each other, to all the organs, to ensure that the outcomes and the recipient operation go smooth. So there are four key pillars which I find with my experience that which really translate into success for the recipient surgery. Planning and coordination. Most of the times, the outcome of a surgery is decided even before the incision of the retrieval surgeon takes place because depending on the donor physiology, the donor inotropes that are going on in the donor, the presence of infection, the available logistics, the instruments, the fluid that is available, and the timing of surgery, all that plays into the outcome of surgery. It is also important how quickly, how timely, and in what sequence the organs are removed. How you discuss with your other co-surgeons, the other organs as to where the incision is going to be, that there is no injury to the organs. Technical precision is very, very important. Understanding know-how, carefully respecting the planes of the organs. Remember that nothing is you cannot be too careful in a retrieval surgery. Ensure that you can bring out as much tissue as possible. Don't try to cut corners or don't try to be rough and in a hurry to remove the organs. Don't try to do it like a recipient operation. So leave more tissue. You can always remove extra tissue on the back table. So be careful, be cautious. All that plays into it, and definitely communication and team dynamics is non-negotiable in a retrieval surgery. So it is very important that all these things are taken into consideration. I feel that once all these key principles are followed, then the outcomes across all organs will be smooth. So thank you very much for listening to me.
Thank
you,
you,
ma'am.
Vaishali. That was very comprehensive. Sorry, Dr. Akshay, please carry on.
No, sir. I mean, over to you, sir. Please, your comments, sir. Please.
No, I think that that is very comprehensive. I think Dr. Vaishali has taken us through a step-by-step journey of the entire process and has highlighted many of the key things that are getting more important now, because now for a long time we were actually focused only on liver and kidneys only, and but gradually, as I mean, Vaishali herself has a lot of experience. We are getting more. We are evolving more in our program. We know that ancillary use of other organs, pancreas, small bowel, is also important, and definitely our retrieval techniques have to be tailored to safely utilize as many organs as possible. I only had one question, Rajali. I think you've talked about a step-by-step retrieval. Now, we often have situations where, say, for example, in the middle of a procedure, there is hypotension or there is a requirement for a rapid retrieval. So, how does your strategy change if, for example, the uh, operation changes from a elective operation to a semi-urgent one in terms of saving organs and utilizing them well?
Absolutely, very critical question, and I think one which Dr. Mathur had also told me to elaborate on. So these things are not uncommon for us, especially when you are going to a center where the donor is unstable, and if the patient's blood pressure starts dropping or there's bleeding, and you really have to change the way you're retrieving the organs. What we discussed earlier was a step-by-step method, but when you have a situation where the donor becomes unstable, it's always important first and foremost that you have your cannulas in place, and once your cannula is in place, then you don't really have to worry. Start with the cross clamp and let the organs flush. Keep them as cold as possible. The rest of the dissection can all be taken can take place in the cold. So to keep your make sure that your aortic cannulas are in place and you know where you're going to cross clamp. I think once that is done, all this dissection that we talked about, removing the liver, the pancreas, the small bowel, can take place in the cold. And then after the cross clamp, then I think time you have the time in your hands. So important not to just keep on hiking up the inotropes and getting the blood pressure up. You need to understand, talk with the anesthesiologist. If the map is falling below 80, if the blood pressure is sinking, if there is bleeding, then one need to think about how you're going to do it and ensuring the flush is in and perfusion is going on. And after that, you can take your time in dissecting the organs.
Okay. One more question, a specific technical question. Now, if you have a aberrant right hepatic artery arising from the superior mesenteric, in a situation where a pancreas retrieval is also contemplated, then what would be the technical approach that you follow in your practice, in terms of ensuring that we are able to utilize both the organs?
So, am I on mute? All right. So there are two ways of the way I approach it. First is I discuss with the liver retrieving surgeon. So most of the times, as I said, if he's somebody or he or she is somebody who's comfortable with the living donor technique and is willing to divide the right hepatic artery above and give me enough without dissecting the pancreas, they usually divide it at the common hepatic artery level and do an anastomosis at the backbench. If not, then what we do second is you can remove the liver and pancreas on block and then decide on the back table. The third approach, which is if especially if the pancreas transplant surgeon he or herself are at the back table or the retrieving time, then we usually decide at a point where we can divide the right hepatic artery as it originates from the SMA. Doing a gentle dissection if the donor is stable, you have enough time, and the liver surgeon doesn't want to do a cold dissection, on block dissection, then what we do is we identify the SMA and identify the point where there's origin and just divide it so that he can have a good length of the right hepatic artery without entering into the pancreas parenchyma.
Mm. I think you raised a very good point. The difference between, say, most surgeons in the West and India is the extensive experience of living donor.
Yes.
So most of our surgeons are very happy to work with shorter vessels and
Yes.
even finer vessels as compared to, most surgeons who are trained in the West who are exclusively DDLT exposure. So
Absolutely.
yeah. So just to share with Dr. Vaishali that the last 4 pancreas that we have done here have all been done with the on-block celiac SMA patch,
Oh,
because
fantastic.
we have managed to convince our other us only actually with our team
Yeah.
only. We're able to convince our team to divide the common hepatic duct at the level of the GTA, so
Yeah.
that we work with a smaller artery on the liver, but then we are able to save the aortic patch for
Yeah.
the pancreas without the requirement for a backbench construction.
Viagra. So it
Yeah.
saves so much of time and labor for the pancreas
Yeah.
transplant and allows good
So
perfusion also.
So I think that that is a technique we're hoping to write up, because I think that that is probably something that is very relevant in the Indian setting, because I don't think that surgeons, unless you're working with liver surgeons who have the
Yes.
requisite living donor experience, most surgeons would not be comfortable with that.
Because that instances, like I've done those common graft only when the liver was injured or liver was not utilized.
Yeah,
It's a young donor. So these situations are very rare. A young donor with the liver not being utilized. So this having a good collaboration with the liver team and the pancreas team and the small bowel team really works very well for having good outcomes and good utilization.
sure. Thank you, Dr. Ashali.
Thank you,
Uh,
Dr.
uh,
Sir.
I mean, Dr. Pathur, sir.
Yeah. Dr. Plani, should I come in now? Or
Yes, sir.
hello?
Please go ahead, sir.
Yeah. So, Vishali, very good technical presentation, a very simplified way. Now, my comments are in general for when, see, the people who go for the multi-organ retrieval, that means they have more than one surgeon involved, more than one team is involved. And if it is a thoracic organs also, you can have a heart surgeon, you can have a lung surgeon, and you have a abdominal surgeon with the uh, most of the time kidneys are retrieved by the liver person, but then there can be separate people, and so also the small bowel and the pancreas. And now we all know that when there are so many heads coming, each comfortable in working their own environment, okay, there can be problems. And these are the general principle which one should follow when you go to another hospital for doing the retrieval of the organs. Particularly when you are going to a hospital which is not doing the transplants, like non-transplant organ retrieval centers. First thing is that everybody should introduce to the local staff, that is the ward nurses, to the anesthetist, and the rest of the people. Make them comfortable. Okay. Second thing is introduce yourself to all the teams. And before going in the OR, have a communication clearly in what order you are going to do the dissection and cannulations and taking out the organs. And there should not be any fight on the table because that looks very, very ugly. We should all keep our egos at the place where we work. And in a donor hospital, please don't think that I'm such a big surgeon, so they should respect me or this thing. No. Second thing, so the communication between the teams should be very, very uh, important, and it should be done in very convenient. Second thing is, in a donor hospital, don't try to be sarcastic or don't try to shout at the OR staff or the nurses or the anesthetist. That's a bad manners. Okay. It is, you cannot think that your hospital nurses which are used to work with you and this hospital will be, level will be same. Okay. So you should lower your expectations and try to work that way. Third thing is, after retrieval, as Vishali showed that the closure of the incision should be very neat and clean. And it should be pre-decided who is going to do the closure at the end. Because often it happens that people collect the organs and walk out. And the donor hospital has to call third surgeon from the hospital to close this thing, which is a bad thing to have. It is the duty of one of the surgeons, mostly the abdominal surgeons, who should do the closure. The third thing is documentation of all the notes about all the organs retrieved, particularly in the medical legal cases. Now, this is important because these notes are taken as on the postmortem report. So the patient doesn't have to undergo another postmortem as far as the abdomen and chest are concerned. So this is as per the uh, Act, which mentioned that the retrieval notes can be taken as a part of the postmortem report. So it is important to document all that thing. Often people retrieve the organs and they leave and they write some very sketchy notes, which is not the right thing. Okay. So these are my general comments for on the multi-organ retrieval. Thank you.
Yes.
Akshay, some time for me?
Yes, sir. Please, sir. Please.
Yeah. Vrishali, a
Yes.
very elaborate and a very scholarly point-wise narration of the entire process. And I must say, probably there was nothing left for question answers because you covered up each and every point. And subsequently, what Sonal came in was again a technically very valid intervention. And the way you both spoke on it, it was really very enlightening. I could see the scientifically important for a liver and a pancreas surgeon point coming through Dr. Sonal, and the administrative or the allocation allocation body wise important points coming through by Dr. Mathur. So we had a very, this is very important, and we definitely had a very important fallout and a very significant one because of this ego thing playing out in our Nagpur region, ZTCC Nagpur region. We had a uh, steep fall into the number of donations that happened in a subsequent year because of some misunderstanding that cropped up in one of the organ retrieval processes. So, um, I was about to actually put a question to you. Is there a rule that is followed and as to who closes the abdomen in the West, or is it again a collaborative decision? Because here we have issues about this. Mathur sir said about it. It's usually left unaddressed, and then subsequently somebody who has some feeling, some compassion comes in and does it. So, are there any rules about this? Who does it?
So, as I think Dr. Mathur sir and Dr. Sonal also mentioned, in the West, this is taken very seriously. In fact, if the
Yes.
closure is not done in time and not done appropriately, you are marked and you may not be allowed procurement. So, therefore, it is very acceptable that abdominal surgeons will be doing it before starting the operation. Then introduction is done to each other. Plan is discussed. Who will close? Who will start? What time the cross clamp estimated? How do we plan the logistics? So I think that is what we all have to do. I think what you talked about in happening in Nagpur ZTCC is not unique. It has happened at Pune also, and I'm sure it
Yeah.
must be happening at few centers where we have to call in somebody else to do operate.
Yeah.
So that is something we need to have some kind of policy where this kind of behavior should not be really accepted and should be at least, if not punished, at least be told off. So one definitely is to have a decision beforehand who would be closing the abdomen. That would really help.
Okay. So there is no assigned role for any specific team to do it. So it's probably collaborative and has to be mutually agreed upon.
Right.
Second thing was when suppose there's a trauma and that has traumatized the liver also. Most of the
Mhm.
times, where what we realize is that liver transplant surgeons during donor liver hepatectomy, they are happy with a part of the liver and transplanting it, and then there is no discrepancy about the size that the recipient would be requiring. So, in a traumatic abdomen, suppose there is a injury to the liver, do you still have any criteria to probably accept part of the liver? And broadly, what are the things that we as abdominal retrieval surgeons should remember?
So usually, say if there's an injury to the liver or if there's had been a traumatic case, this usually a scan has already been done beforehand to understand what is the grade, CT grade of the liver injury, how deep it is it involving any major vascular structure or not. Apart from that, intraoperatively, when we are there, we look at how the liver looks like, how well it is perfused, is any obvious hematoma there, is how big is the laceration, and if it's a superficial lacerations, this usually are not a problem. If they are grade 2, grade 3 more in the deep, that's when the discussions or liver may or may not be utilized, or only a particular lobe, right lobe or left lobe can be utilized. So all depends on the grade of injury, the CT scan, and the findings intraoperatively. Maybe Dr. Sonal can also elaborate on it.
Yeah, I mean, I think that this is very, very individual and it will vary from surgeon to surgeon. And
Okay.
just because one of the big differences, I think, that between, say, how a pancreatic surgeon or a kidney surgeon would respond is because we know that the liver is a life-saving operation in many ways.
Right.
But it will, we may accept organs which are slightly more marginal if we think that we have a very, very sick recipient where there are no options. And
True.
I guess the only thing that would be unusable from any criteria is there if there is a devitalized liver, if there is a type 5 vascular injury, where there is a liver injury to the vascular pedicle, and then that liver may not be usable. And even like already mentioned by the participants, even in that situation, you might want to be still able to resect a part of the liver and utilize the other part. So I think that each of these will be taken on a case to case basis, and certainly it will be taken with the recipient in mind. Because we will need to know what is the risk benefit to the potential recipient that we are actually doing it, and
Yeah.
that's there. But I would say that the only answer is that do not write off any patient just because there is a liver injury. Please
True.
ensure that the scan is done, the information is communicated, and then even if the first sort of allottee may not want to use it because they have a stable patient, but thanks to the ZTCC and allocation authorities, they can actually match organs even better from a risk and benefit perspective.
Yeah. And just one short point. Third point is probably Rishali and Sonal, both of you can put your views on it. After the cattle brush maneuver has been done, what lies in front of us, as you said, the aorta and the IVC. Besides that, even the right kidney lies exposed completely. So, in a stable donor, is there uh, any issue if the right kidney is probably harvested in a heart beating condition prior to the aortic clamping?
And let Roshali take that.
So I have been requested these. I think these requests have been made to me when I'm operating or gone for retrieval, and so usually I assure them, see, if done in a very synchronous manner, it doesn't take much time once the cold
Yes.
flush has taken place. My
Yes.
only worry is that sometimes the retrieving kidney surgeon who's there may
Mm.
not be as experienced as anybody, every person, or might not be the person who's going to implant. If for
Yes.
some reason while dividing the, because the right renal artery is higher up,
Yeah.
origin is higher up,
Mhm.
and its right renal vein is very close to the IVC.
Yes.
Sometimes it's a very short, stumpy vein. So in there, hurry to do the warm dissection that might dissect too much of the retroperitoneum for the pancreas and might
Mm.
devascularize the duodenum, C of the duodenum. Secondly, even if you have reflected it medially, any if there's any bleeding occurs, it might again exsanguinate or cause hypotension and might have to suddenly change everybody's plan of action. And
Right.
sometimes the heart team is not ready, sometimes the logistics not in place, so might lead to us not utilizing the organ. So why induce an inflammatory response or anticipating bleeding? So if it is not too much of a problem, I try to convince them that once the thoracic organs are out and the organs are flushed, we'll do a quick sequential manner of organ retrieval so that the recovery process is not tedious and not prolonged. And after removing the liver or pancreas, sometimes I personally help the kidney surgeons to retrieve the organs so that there's not much time wasted.
Mhm.
So I'll give a short answer. It should never be done. Okay.
We'll
Because
have
because
some
because
numbers.
for the no,
Yes.
I'll tell you a principle. The primary
Mm.
principle, as Dr. Mathur will agree with me, of any retrieval surgeon is to ensure that the maximal number of organs are retrieved
Mhm.
effectively. Because when you go there as an ambassador of transplantation, it is not you're not going there only as a liver surgeon or a pancreatic surgeon or a renal surgeon. Your
Yeah.
job is to make sure that the gift of life is given to as many people as possible. So any action that would potentially impair that should not be done. So anything that adds to even a simple thing, you're mobilizing a
Ability.
kidney, you suddenly get a VTAC. It happens so many times, you know. Suddenly, for some reason, you have converted a stable situation into a situation which leads to the loss of so many other organs. Okay, and
Right.
equally, there is no merit in saving half an hour or 45 minutes of
Liver.
not even ischemia time, of dissection
Right.
time for a kidney.
Right.
There is
Right.
actually zero merit in that. So there is a lot of risk and no benefit to this, in my opinion, because I know that a lot of, again, it comes from our living donor training. A lot of our Indian surgeons are very happy to retrieve kidneys in a open setting because they know how to do living donor transplant. And this entire thing about on block that Vishali is talking about is foreign to many people. Okay,
Yes.
but
In fact,
it
the
is not
most
about
experienced.
playing to your comforts. It's about
Yes.
ensuring that you are utilizing all the organs in as safe a manner as possible. And I
Right.
mean, we all know that sometimes we have to wait because heart teams are not ready or their flights are not ready. We have to wait 2, 3 hours. It doesn't matter because we have to make sure that as many organs are utilized as possible. That is the primary credo of a transplant surgeon.
Yeah. We'll have some occasions and probably uh, situations wherein this approach probably will prove to be beneficial. I think we should not, right now, it is just speculation, but we definitely have numbers in saying this. And there are occasions when waiting 2, 3 hours for a team to visit and begin the process they also prove costly if the donor gets away out of our hand, and we probably cannot, just because of trying to wait for the larger organs to come and retrieve it. We many times lose not getting even a single organ in our
No, no.
conditions,
That
I can say.
I mean, see, everything is contextual in that. What I would say is that obviously, if you are getting unstable, if, for example,
Precisely,
you are
Sonal.
waiting
Yeah,
for a heart, I mean, it
yeah,
happens so
yeah,
many times. No, you're waiting for
yeah.
a heart and you're unstable, map falls below 670 for a long period of time. Then you go
Right.
in and you retrieve whatever is possible. I'm
Yeah,
not
yeah,
talking about that situation.
yeah,
So
yeah,
it is contextual to that point that obviously we are nobody's asking anyone to wait and lose all the organs just because you want to get the best result.
yeah,
But
yeah.
wherever possible, you know, the focus should be more than your organ.
Yes,
That is the
yes.
point I'm making. Even Dr.
Yeah,
Mathur is making that point. You are an
right,
ambassador for transplant. You are going
right.
there, you're
Yeah,
directing transplant to a larger group. You have to
right.
be thinking about more than just the liver or the kidney that you're going to bring out. I think
Yes.
that is the point, that the larger point that we are making here.
Yeah, yeah. That's understood, Sonal, and point is taken. Probably we'll have a better explanation to give when we speak on this few months from now. Let's hope. So, thank you so much. Thank you for deliberating so in a detailed manner on all these points. And over to you, Akshay. Probably we can
Yes, sir.
carry on now.
Yes, sir. So thank you, Vaishali ma'am and the chairpersons today. Let's quickly move on to the kidney only retrieval part. Muruganandam sir, the stage is yours. If you can please present and begin your presentation.
Yeah.
Yes, sir.
Thanks a lot. Am I audible and visible?
Very much, sir. Please go
Yes.
ahead, sir.
Okay. Thank you. I think it was a wonderful talk to listen. All the main points which are related to the overall discipline of organ retrieval, and also the individual steps was nicely mentioned by Mrs. Patil. It was nice to, and the comments also very valuable. So my job is actually made simple, and I'll be making a very short presentation. And when you have a liver surgeons available, they are harvesting liver, then things are very easy. They dissect entire thing. They are very good in the cross clamping and the cannulation. It's easy. Once the liver is harvested, the kidney retrieval is very easy. But there are very few occasions where, like as we went through when 15 years back when we were in Jipmer. So normally the kidney, they will start with live, then they go to cadaver once they mature. So the liver, they'll start with the cadaver and they go to live when they mature. This is a normal this thing for any institution. For our institution, we started doing live for 2 years. We wanted to do cadaver, but by the time the liver, the permission was not ready. So in Pondicherry, the union territory, so we had a certified brain death donor and our kidney transplant patients were ready. So at that situation is where I'm going to talk the cadaver kidney only retrieval, where the transplant surgeon or the urologist in that center has to harvest and also the transplant. There are so obviously I'll go through the step one by one. So the plan and prepare, it will be usually you will be in out of the time. You should have a very good colleague with you who can assist you in sync, where to cannulate, when to put the tie and all. Generally, I tell you the problem we face is kidney retrieval is not a big thing for a surgeon who is routinely doing urological procedure and oncological procedures and doing a live transplant, either laparoscopy or open kidney retrieval. Okay, the extra steps which, for example, the dissection is entirely similar to what we do for a retroperitoneal lymph node dissection for a kidney cancer or a testicular cancer. The entire cattle brush maneuver and going up to the renal hilum, all things we do. And the only two things we are afraid are the supraciliac control of the aorta and the aortic cannulation. These two are the only the problems. So I have heard from the other centers where the senior surgeons will resort to kidney only retrieval by adopting the same technique as the open live donor. Say they do the left side first, then they do on the right side with IVC cuff, left side with the renal vein at the junction of IVC. But as Dr. Sonal is rightly mentioned, this should not be done because as we mature, the India, the program is getting stabilized. So everyone has to be trained for a multi-organ retrieval. So thanks to ISOT and our association like Urological Society of India, we have got a separate section on the transplant surgery where they conduct regular the workshops in cadaver for these training to the urologists, which is very important. So the planning and prepare, as I said, the cannula should be available, the perfusion fluid should be available, and many times the incision is not the issue. Very rarely we extend into the chest. On the rare occasion we are not able to have a control of suprailiac aorta, then easy to open the diaphragm. At the crux of the diaphragm we can control the aorta. This comes as a last resort. Otherwise, it's a midline incision from the civis sternum to the pubic symphysis. And coming to the retractors, the ball 4 comes easy when we are using two retractors, one on the top, one on the down. And if your the phenocity comes very handy, especially in the upper abdomen. And Thompson retractor is the one which will serve all the purposes, retracting the bowel and keeping your abdominal flaps outwards. When it's an obese patient or it's a difficult to access to the lateral, we resort to T-shaped extension from the near the umbilicus to make the exposure more wider. Right. So as exposure, this already has been discussed. We routinely do the Cocker's maneuver and the cattle patch maneuver, which is there. Everyone will know. And once we do these steps very nicely, the inferior mesenteric artery is ligated and that will expose completely the IVC, aorta, two ureters till the pelvic brim. Then we go up to the renal hilum higher than the junction of the renal vein to the IVC. So till that time, the dissection comes easy. As I told, we ligate the inferior mesenteric artery for the proper exposure and they expose the left upper quadrant by splenic and also the pancreas mobilization at least till the midline to have a good access to the left kidney upper pole. And the most difficult part initially when we started the program is the superior mesenteric artery ligation, which will be very thick for a urologist. And as Dr. Vrishali has pointed out, if you lift the bowel vertically up, then we can expose a good length of superior mesenteric artery, double ligate and divide to have the above the celiac artery to have a good control. So this exposure is important. On the right side of the picture, you can see the retroperitoneal anatomy. The kidney on the both sides, right kidney is lower down. As rightly pointed out by one of the panelists, it is very visible, including the veins. The IVC and the aorta bifurcation, and the ureter below the aortic bifurcation. And many times if you are having imaging available, there can be two ureters. We have seen sometimes the ureter, the problem here is we should not dissect in between the two ureters. Then we lose the vascular supply of one ureter. And it has to be properly re-implanted in the bed using either a Wallace technique or a individual re-implantation. So this is how the IVC is seen. Your aorta is nicely seen. The renal vein on the right side, just below the gallbladder, and the left side renal vein we can see, and the gonadal vein anatomy. Once you get this, then we are ready to dissect into the superior mesenteric artery. We have dissected. Then, okay, what are the vascular control we take? The inferior aortic control, superior aortic control, the IVC. Out of which the aortic control easy to dissect both the common iliac artery or the common aorta just below the inferior mesenteric artery to have a loop, 2 loops. Keep it ready. Then we'll go higher. The superior control can be obtained after ligating the superior mesenteric artery and the celiac trunk, or if you are good enough, you can mobilize the left lobe of the liver using the crux of the diaphragm as a control. You can control the aorta there. And IVC control is relatively easy, and you need just venting of the fluid back. Okay, so this is the most important arterial cannulation and perfusion. So we take 2 stitches, one the umbilical tape or a thick silk, and below another thick silk. The fingers are good to have the nicely fitting around the cannula so that the bleeding won't hit the roof. And the assistant should be ready enough to lift up the umbilical tape and ready for snugly tying around that. Then we'll take another stitch and tie the cannulation once more. That gives the stability, and also should not be slipping back. And we have seen 2 times where the cannula gone higher than the renal artery, and even after retrieving the liver, the kidneys were not perfused well, it was patchy. So after prolonged, the cold perfusion did not happen into the kidney, that organs we had to retrieve. So the distance of the insertion of the cannula is very important. It should not cross the renal chyme, probably 4 to 5 centimeter from the puncture site should be okay. By that time, it should be connected to the TUR set, primed with the fluid, perfusion fluid. Once this step is cannulation is done, then we'll do the aortic cross clamp. By the time the ice slice should be ready, and as rightly pointed out by the previous speaker, we should have the ice slush, not the hard ice. The ice slice should be put over both sides kidneys till the ureters and the pelvis. Wait for some time to cool. Then focus on one side. Then we'll complete on the other side. So there are two techniques of kidney retrieval that also was earlier pointed out. The en-bloc retrieval. You cut the IVC at the junction just above the inferior mesenteric artery and lift the entire aorta and the IVC, work on the anterior longitudinal ligament of the vertebra, and keep every tissue along with the vessels and work on that. And by the time the ureters are kept packed along with the artery upwards, lower pole of the kidneys are also dissected simultaneously. Then the mobilization will come from the top to bottom so that the entire kidney periphery to the perinephric Gerota's fascia is dissected, is free to move. Kidney alone retrieval will cut the aorta just above the renal junction of the artery. Sometimes the renal artery origin can be higher up. Extremely rare, you can have even thoracic origin. We have not seen that. But generally, we'll try to trace the right side renal artery and left side renal artery. It should not be accidentally divided. The other technique is in situ. You split the kidney in situ. I don't do this, but many surgeons do in Chennai. They split within the body. The kidneys will be delivered separately and placed in the cold solution. So after that, what generally these another question: who will close the abdomen? In our center, before that, there is one disclaimer that actually for the past 10 years, I have not done any kidney alone retrieval in our center because we have done close to 15 to 18 kidney retrievals when we were JIPMER without other organs retrieval. So nowadays we do only the multi-organ retrieval. The liver surgeons, they do the aortic cannulation clamping. They will retrieve the liver after we retrieve the kidneys. So what will happen is we'll retrieve the kidney. The liver surgeon will come back for harvesting the iliac vessels. So one of them will close by the time the kidney surgeon can do the perfusion again and look for any arterial anomaly or any other abnormalities within the kidney. And as rightly pointed out, it should be talked much in prior. The closure of the abdomen and chest is very, very important and timely because patient's relative will be waiting outside. This should be given a due importance. So the confidence, my job is to give the confidence to the surgeons who are in the tier 2, tier 3 cities where the organ harvesting retrieval centers are being promoted by the government, where they are suddenly exposed to only kidney retrieval. So for them, the kidney, the good part is the kidney can withhold the warm ischemia slightly longer, and once it's cold perfused, it can you can take, as I told, up to 2 hours even to retrieve the kidney. And routinely when we do the live donor kidneys, we know how to deal with the smaller arteries by multiple arteries. The worst case scenarios, we can deal with the arterial problems even in the bench and also at the recipient site. You know, need not be hesitant. And when we are retrieving, something goes wrong. For example, for us, once the superior mesenteric, the ligate is slipped. Luckily, we could quickly get that with a proline stitch. We could go ahead. But suppose if the surgeon is not comfortable at that point, we can keep that the bleeding controlled with the thumb pressure, and a retrieval surgeon who is very comfortable as a open live donor nephrectomy, he can separately do a right side and left side quickly transplant. This is also possible. Only problem is with the shorter veins and we can't have the aortic patch. Sometimes we have to do two arteries separately. These are the problems. This should be done only in the worst case scenario. So my confidence to the urologists who are starting is, first of all, you attend the program. Nowadays, ISOT conducts, Urology Society of India conducts in Bombay, in Chennai. 2 months back, we had a wonderful cadaveric workshop in Rayapeta where I was one of the faculty. We did only kidney retrieval in 6 different cadavers, focus 3 or 4 students per table we did. So these situations you should make use of it. Even though we should know the one kidney alone retrieval as a backup, we should never don't learn that as an isolated kidney retrieval. Do always learn as a multi-organ retrieval. Learn to work in sync with the abdominal surgeons like liver surgeon and the pancreas and small bowel surgeons. Always good. You can learn from them and you can contribute. And at the worst case scenario, you can deal with the problems. Just learn the aortic cannulation, the ligation of superior mesenteric artery, and control of the aorta at the level of celiac trunk. These are the specific thing you have to be good at it. Then this surgery will be a reasonably good surgery. And you can call there are 2 kidneys. One will belong to the institute, other will go to the common pool. If you're not confident, call the surgeon from that side, a senior surgeon preferably. Keep them along with you to do a safe kidney retrieval. So I think these are the points I wanted to give. All the technical points were nicely mentioned earlier. So I once again thank the ISOT and the Kidney Transplant Surgery Update Committee, especially Dr. Akshay, who are coordinating with me for the wonderful opportunity. I'll be happy to have a discussion and answer your questions to my knowledge. Thanks a lot.
Thank you, sir. Thank you so much. Kolte sir, your comments, please, sir.
Yeah, it's a very lucid presentation,
Yes, sir.
and uh, very rightly said that we have to learn and to respect the donor family issues also, and we should be compassionate about closure. And
Yes,
as pointed out by Dr. Muruganandam, it's
yes,
usually so that the liver guy comes after the kidney retrieval for the iliac vessels, and then he very cordially agrees to do the closure in most of the cases, and that's how it ends. It all ends, and it's quite well accepted and agreeable to everybody. Otherwise, even the person who takes the second kidney is more than willing to do it most of the times. But usually they are hounded by the nephrologist to get the organ as quickly as possible. That's the scenario unique to our country. The nephrologist otherwise is not involved in the deceased donor transplant program at all in the West. They
Yes.
usually come into the play only when the surgeon calls them. Probably that is also 3 or 4 months later. So there are different. There are situations which are unique to the Indian scenario, and that is why the most experienced transplant surgeons that we have in the country are the kidney transplant surgeons.
Hmm.
And that is a very reason why we have to have this webinar today. And so, thank you, Dr. Muruganandam. It was a
Thank you, sir.
wonderful deliberation. Yeah.
Thank you, sir.
Mathur sir, any comments, sir?
No, but see, Dr. Muruganam has correctly said that the more and more urologists should learn the retrieval of the organs from the cadaver. Okay, because I have found that often in the middle of the night, if the liver is not to be retrieved, only kidney retrieval is to be done. I have to actually request the liver surgeon to go and retrieve the kidneys, because most of the people who do the renal transplant, they don't want to get up in the middle of the night, number one. Number two, they say we are not used to do this aortic annulation and all that thing. Okay. And sometimes the donor, if it is crashes, they don't know how to do the job. And somehow I find them reluctant to learn the technique. So I'm sure that through the ISOT, more and more urologists should be trained in retrieving the organs from the deceased donor.
Right, sir. Roshali ma'am, please, ma'am.
So I just had two questions to ask, or maybe 2 points to discuss with Dr. Murugan, and an excellent presentation, sir.
Thank you.
And one was, I agree with you, there were two sensitive points which I found, which one is where the IVC is cut for the right kidney by if there's a liver surgical team. So having that discussion beforehand, usually I tend to use a marker pen saying that at the where the right hepatic vein. So normally the right renal vein should not even be identified.
Yeah.
Just at where the left renal vein originates, just at that level, a marking pen should be there so that the right renal vein is not compromised. Very often I've seen that the surgeon obliquely cuts the IVC, wherein the right renal vein gets exposed, and therefore it's difficult for the kidney surgeon to anastomose. And second, that in a rush, both kidney and liver surgeons, when retrieving the kidney, the ureter can get stripped off very easily.
Yeah.
And in a deceased donor, the length may not be that big as the living donor surgeon can sometimes give it to you. So that could be a problem. One of my pet peeve is that maybe Dr. Sonal would also agree, and Sir would also agree, is that the packaging and the retrieval is the retrieval is talked about most, but the packaging of kidneys is something that we see suffering. While liver and heart and pancreas and small bowel and lungs get packaged in a very standard format, unfortunately for kidney surgeons, the kidneys are sometimes not packed in the most standard manner, not nor put in enough solution or put in a cold solution or packaged in steel containers. What is your experience? Do you also see this problem?
Yeah. So we have actually since our Chennai we're doing for quite long time. We have seen all types of whatever you said, right renal vein getting divided,
Right,
absolutely no IVC cuff, and not perfused. Both the kidneys were not perfused, and another is the frozen kidneys during the package directly on the hard ice. So
right.
frozen kidneys we have seen, and division of the arteries, and division of the left renal vein. So all kinds of injuries we have seen because everyone was learning at the time. On the liver team, generally they are all trained in the West. So when they are there, they do the quite this thing. So we have seen the technique to prevent all this is to learn this technique as a multi-organ retrieval along with the abdominal surgeon and also thoracic surgeon. That is the only way to go, I believe. And for the urologist who's watching this talk, so one more thing, as I told, the only two things you will be worried about is the aortic cannulation and the supraciliac control. And many centers may not have the liver surgeons who are available because very few centers can afford to keep a full-blown liver team. It's quite expensive to keep a full liver, but they can have the CTVS team or a vascular surgery team. So in the times where you are in the need, at that time, they can also be of help to cannulate and control the aorta. This also we have talked and it worked because Tamil Nadu has got many vascular surgeons. MCH vascular surgery started much before. So in Tamil Nadu, there are many tier 2 and tier 2 centers. More and more retrieval only centers are being formed. This is another point I wanted to make. Thank you.
I mean, this is a question to Dr. Mathur sir and Dr. Kolte sir and Dr. Subramaniam sir. If as a ISOT and as transplant leaders and who are overseeing and mentoring all of us across pan India, is it possible to have some kind of guideline where any retrieval surgeon, whether it's a liver surgeon coming in or a kidney surgeon coming or any abdominal surgeon who's going for retrieval, has at least been a part of or assisted multi-organ retrievals, at least five of them? Can there be some, because having assisted at least five multi-organ retrieval will open up the perspective and understanding of how to really do it in the right way. Can this be a, because right now once you register the DHS, one can become part of retrieval. May not necessarily mean that you have been a part of the transplantation and retrieval program. Any cardiovascular surgeon, any GI surgeon can be a part of it. I do think that some amount of training or being a part of the surgeries will really help preventing wastage of organs. We saw at least 40% of organs or kidneys wasted last year because of injuries, because of reluctance, because they think it was not well perfused, because there was hard rock, ice looked ischemic. So a lot of these things can be prevented. What do you think, sir?
Your points are well taken, Vishali, but unfortunately, we Indians are literally splurging on organs, not utilizing so many of them at so many times when they could be very nicely employed. Not only from usage point of view, from harvesting point of view, but even enlisting of heart uh, failure patients for heart transplantation is not done. So many years it's been at Nagpur ZTCC. We are appealing cardiologists, we are appealing to the general public to make them, realize the value of heart transplant. But not a single person in so many years has been enlisted for a waiting list of the heart in our region. And all the hearts that we uh, get through the donors, they are either transported reluctantly to distant places because people coming from far away, as far as Chennai, Delhi, Ahmedabad, Hyderabad, they also many times refuse it for logistics because they become very expensive to hire a chartered flight and come and take them away. So we are actually not utilizing the organs. Most of the retrievals that happen here are the liver and kidneys. That's it. It's almost now 12 years into deceased organ donation in our region, but the scenario is like that. With regards to making or ensuring this, we are repeatedly putting these requests to the NOTO and even through ISOT in whichever way we can convey to them. They are very good listeners. They are very good takers of points, but implementation, execution, enforcement is very, very weak. And it's just last 3 4 years we are seeing some action coming from them. Otherwise, the central government is really very slow in acting on all these issues. But you have a valid point. I think all of us, if we have a exposure to five multi-organ retrievals, it will definitely make better organ retrieval surgeons, and they would definitely be very useful at NTORCs, which are again very poorly distributed throughout our country, and many organs are otherwise wasted because of non-availability of expert retrieval surgeons in tier 2, tier 3 cities, or even the remote corners of the country. We are pushing it in our own some possible way, and Noto has ears, as I said. Let's hope they work on the execution part also.
Yeah. So one of the suggestion I can give is that we have MCH courses, right? Both in GI side and we have got on the urology side going on for a long time. Board of Studies can introduce a clause that everybody who is going for MCH exit exam should have done at least 5 or 6 kidney cadaver kidney retrievals, not only just renal transplants. So that can be made the prerequisite, and I think they can be then, if the center is not doing the cadaver transplant, they can be sent to some other place for training.
I think, sir, for this we need somebody of your stature to enter into the uh, shoes of the Noto. Otherwise, Noto has unfortunately people who cannot really perceive things as a transplant personnel can, and they have their own ways of acting, and they also may be having their own limitations in carrying out our suggestions. But yes, we have also put forth to them that the concept of brain death probably should be introduced in the school curriculum itself, so that the general public is aware about the concept and we do not face refusals uh, on so many occasions. We, out of probably 10 potential donors that we counsel, the number of conversions are hardly about 10 to 12, 10 to 20%. One or two out of the 10 would be willing. So it's primarily, and even those who are willing, they are the ones who are aware about the concept. They do not yield to the counseling procedure as such. They are aware about the concept and they themselves volunteer, and only those could can uh, go ultimately to donation. So the concept has to be introduced, and for that again we have to plead to the government to see to it that the NCRT books, the biology books, they have this concept explained as a chapter on brain death or disease donation. So we have been just suggesting all these things, and slowly things are moving. Let's see when it happens.
Right, sir. One quick question to speakers and chairpersons. Sir, when time is a factor, especially if we see the scenarios of DCT donors, any Muruganathan sir, can you please, or Vrishali ma'am, if you could just share some quick tips on how to go to the supraceliac aspect quickly so that we can have a clamp and then start the perfusion. Any tips to get to the supraceliac segment quickly?
So, so what I'll do is what see once you identify the esophagus, retract the esophagus using one of the either malleable retractors or you've got a small finer devers. And if you push, you can feel the ice tube in the esophagus. So you know this is the esophagus, right? Once you retract the esophagus laterally towards the left, what you can feel the aortic pulsation immediately in that space. And once you feel the aortic pulsation, so there's a huge crust over there, left and right margins are there, that you can put a right angle and divide it gradually. And you can, while feeling the aortic pulsation, you can go around the aorta or at least identify a big chunk of the aorta. It's really not that problematic. Once you've exposed the left liver is retracted towards the right and the esophagus is retracted medially. It's easy to identify the supraceliac aorta.
Right.
It's more of a anxiety and not knowing that causes a problem that, because this is actually a big aortic vessel, very easily found.
Right, ma'am. Also, Murugan sir, as you mentioned that injury to the hilum, when we are doing an on-block kidney retrievals,
Yeah.
better to be, away from the hilum, dissect outside the girotas, include the ureters in your dissection. So if we have a wider dissection, the lesser the structures damage in medially. And then it depends on the both the teams of the both centers from the kidney whether to cut the IVC and iota either on the table or on the bench. Right. And one question from all the stalwarts here who've been doing transplants for so many years. Kolte sir, also from I would like to hear from you, sir. So there are reports of an aberrant vessel or maybe a renal artery, probably originating from the thoracic aorta, or maybe somewhere high up, which is not anticipated, and obviously donors don't have that much of imaging done. Um, any experience on that, sir? I mean, how can we have some surprises, or can we prepare ourselves for such surprises sometime? Is that possible, sir?
Yeah, actually, Dr. Sanjay can told because I never encountered the thoracic aorta only in the textbook, but aberrant arteries are very common. You pre-IVC renal artery which is coming from above and multiple vessels, one coming having a loop around. Retroaortic renal vein can get injured when you want to split the kidney. So these are the things I have encountered, and surprises always will be there. You should be having a zero mind to avoid the injury. So probably Dr. Sanjay can add more.
Yeah, it's quite common, I can say, in the sense out of say about 10 kidneys that we get, on one or two occasions we do get accessory vessels to the kidney which have not been uh, looked at or which were not probably detected. And what we find is a stump at the lower upper pole or at the lower pole, a small twig of artery, which is not really wide enough to be anastomosed, or many times we do not find any plan or available resource in the recipient which can probably be anastomosed to that small twig. And then we usually end up accepting a small area of ischemia on the kidney. Nothing can be done on the bench as well, because the artery that we get is usually the twig is not recognized as far as possible during the retrieval process. So encountering small twigs which were probably neglected, ignored, or not detected is not very uncommon in the scenario that we have here, because unfortunately for me, I can speak from a region where multi-organ harvesting has happened very less number of times. In the last almost about ZTCC Nagpur has had about 190 donations in the last 13 years. Of these 190, we probably had just about 25 to 30 wherein the heart, lungs, and all other abdominal organs were utilized. Pancreas has not been utilized even once in all these donations. But the remaining 150, 160, you can say, have been just liver and kidneys. So that is where the entire scene ends for us in the TCC Nagpur. And with this limited experience, with limited expertise that we have, it's not uncommon for us to encounter ignored vessels, and then probably grappling with what we can do with them. But more than often, we usually try to anastomose them to either the lower polar ones to the inferior epigastric arteries, or to one of the branches of the intrailiac artery, or suppose the twig is long enough, then an independent anastomosis to the extrailiac artery as well.
One thing I may like to add, sir, the accessory arteries multiple. Sometimes you may not get with the aortic cuff. We have seen the
Yes,
artery get injured. Finding out the artery will be difficult sometimes.
yes,
So
yes.
we had two, three occasions. Actually, one technique which helps is a retrograde perfusion. You perfuse through the vein,
Yeah.
then that fluid will be seeping through the artery. There we have found out. So there are occasions we have done this technique.
Right, right. Just yesterday, I had the opportunity to do both the kidneys in one donor. Both the sides, there were two arteries, and both the accessories were at the upper pole. The left side probably had a aortic patch along with it. The right side had the small twig on the upper pole, which was again the recipient had an inferior gastric, which was totally sclerosed and calcified. Internal iliac was totally blocked. So the only artery which I had available on the right side kidney was the extra iliac and the twig was very small. I could do nothing with it, but it had just about 3 or 5% of ischemic area at the upper pole, which I could easily ignore. Had it been on the lower pole, I would have been worried because the ureter also gets its supply from the lower polar arteries. So that is how things are.
One trick
Right,
that
sir.
I've realized is that if the when dividing the kidneys, if somebody wants to divide them in situ, sir, the IVC should not be divided. It's usually once when the IVCs try to be split intraoperatively, the renal arteries which are accessory because they are crossing from the IVC to the aorta, they get divided. So therefore, if I can just quickly share one slide which probably can so this kind of picture. So where the IVC should remain with the as an entire length with the right kidney, will prevent any accessory arteries or multiple arteries on the right kidney being injured. Well, as compared to the left kidney, as we split the aortic cuff, you can at least see the small origins coming from either from the celiac axis up to the down at the bifurcation of iliac. So those arteries can also be saved. So this sometimes can help prevent arterial injuries or giving small arterial cuffs. And of course, if you end up having small arteries, like you mentioned, the inferior epigastric artery with the gonadal, they can be used as conduits or attachment for anastomosis.
Right.
So these are just my
That's how we do it, Rishali.
correct,
The
sir.
right side gets the entire IVC, but
Right, sir.
despite that, whatever
Sometimes.
comes our way, so suppose the twig at the upper pole, if it was coming through a thoracic portion of the aorta, probably
They
that was
was
unrecognized. So retrospectively, it's difficult to find out where and what went wrong.
true.
But yes, we have to deal with such situations.
Right, sir. Sir, all the panelists, if there are any last comments, um, Mathur sir, any last comments from you, sir?
My comment is that more and more surgeons should be trained in the retrieval of the multi-organs.
Right, sir.
My
And
comment
platforms
is,
like
sir,
these, sir, we are trying our best to.
yes,
Yeah.
yes,
Yes,
we
sir.
should have official training in multi-organ transplants, sir.
Yes.
In fact, there should be departments developed for multi-organ transplants. Like
Transplants.
we have all the liver and the, I can say all the non-kidney transplant surgeons in the country are fellows that were trained either in the West or in somewhere in Korea, and the kidney ones are the homegrown ones, and unfortunately they are left out with, even if they want to learn other organs, there's no way they can actually get the training. Official training also is so difficult. I know one example wherein a very senior surgeon, probably a year or two senior to me also, graduated from kidney to liver, and in the initial stages of his liver transplantation he had to face a lot of criticism about not being trained in officially in liver transplant surgery. So the will to learn is not lacking anywhere, but the legalized training is nowhere. I think if the government recognizes this aspect seriously, there's no harm. There's nothing actually stopping them from opening multi-organ transplantation departments or hospitals. I think it's the Gujarat University of Transplant Sciences is the only university which is offering something credible to somebody who aspires to do multi-organ transplant learning. Otherwise, just by stating or having a wish to be trained, you don't really officially get eligible to do multi-organ transplantation or just even retrieval. Any problem that crops up, you are vulnerable to being legally punished, legally prosecuted, or at least legally tried for having done that or having ventured into that. So our law is very, very stringent and very, very aggressive, but our training and the concept behind the training intention to train are really very weak. That's where our expertise fails. We have to probably keep on appealing till this happens someday.
Right, sir. So on that note, I would like to thank Vrushali ma'am and Muruganandam sir for a very, very comprehensive talk in the given time period to cover so many points and so well. So thank you, ma'am. Thank you, sir. And a special thanks to Mathur sir to have agreed to chair today's session. Sonal sir and Kolte sir. Sir, thank you very much. And thank you to all the audience for joining in and trying to learn from these stalwarts. Thank you very much. And I think if we are okay, I think we should close the session now. Thank you very much.
Thank
Thanks.
you.
Thanks.
Thank you, sir. Thank you.
Thank you. Yeah. Bye.
Thank you. Thank you.